welcome to Brain Chat. I'm Dr. Mitzi Joy Williams, your board-certified neurologist and fellowship-trained multiple sclerosis specialist. My mission is to engage, educate, and empower those impacted by chronic neurologic conditions to become an active part of their healthcare team. Here on Brain Chat, we'll be discussing all things brain health, wellness, self-advocacy, and how to care for your loved ones who are impacted by chronic neurologic conditions. Join me and my super friends and special guests as we get ready for the next episode. And most importantly, let's get nerdy. Hello, everybody. Welcome to Brain Chat. Happy Monday. It's Dr. Mitzi, the neurologist, and I am so excited to be here with another episode with one of my super friends and really good friends in real life, Dr. Tamara Green. But before we get into our discussion, we first like to thank our sponsor, the National MS Society, and I'd like to thank all of you for tuning in and listening to or watching our program. All right, so let's get into it. Today, we're going to be talking about symptoms of neuropathy, which I think is really important because people can have nerve pain for a variety of different reasons. And we're going to get down to a little bit of the nitty gritty, and most importantly, the ways that we can address or deal with these problems with my special guest, Dr. Tamara Green. She is the medical director of the Green Neurological and Medical Consulting Group in Atlanta, Georgia. Welcome, Dr. Green. Welcome to Brain Chat.
Good morning. Good morning.
All right. So we are so excited to talk about this topic. And I think it's one that we don't talk about enough, right? Because nerve pain symptoms of nerve damage can come from a variety of conditions, but all nerve pain is not necessarily neuropathy. Sometimes we have to distinguish it from different symptoms. But before we get into that, first, tell the people a little bit about yourself and how you got interested in neurology.
Well, again, my name is Dr. Tamara Green. I'm originally from Tennessee, and I became interested in neurology after seeing the residents in neurology during my third-year rotation. They were just very joyous people. They were happy people. Prior to doing my neurology rotation, a lot of the residents were just absolutely miserable. And then in getting in the midst of the rotation, there were just so many interesting things about neurology to learn. I noticed that it was an ever-growing field. There was so much research being done, and it just matched my personality. My attendings were wonderful. They were just normal people that just so happened to be super intelligent nerds. So I thought I would be a good fit for the profession.
Awesome. Because, neurologists are nerds, right? But we're cool nerds. You know what I mean? Like, we're cool nerds. All right. Very cool. All right. So now tell us a little bit about neurophysiology. So you did additional training, to do tests like EMGs, et cetera. So tell us a little bit about the field of neurophysiology and what kind of training and what that entails.
So I actually did two fellowships, one in clinical neurophysiology and the second one with neuromuscular medicine, which also deals with clinical neurophysiology. So neurophysiology primarily deals with the electrodiagnostic aspect of neurology. When I say electricity, specifically using electrodiagnostic studies like EMG, which stands for electromyography, nerve conduction studies, as well as EEG, which in essence stands for electroencephalogram, to monitor the brain waves. So what the EMG does, it utilizes a really tiny needle to look at the muscle potential or muscle electrical activity. The nerve conduction study uses electricity to utilize and look at how well a nerve is conducting its electrical impulses. So a lot of organ systems utilize electricity. And in essence, what the neurophysiology component of neurology does is assesses the ability of how well nerve, muscle, and even brain waves with EEG, how well they're conducting their electrical impulses, or if something's abnormal, where's the abnormality located?
Mm-hmm. Absolutely. And I think it's important because, sometimes when people see neurologists, obviously, number one, they think we can solve all their problems, right? Because everybody's already told them, I'm going to send you to the neurologist and they're going to figure out what's wrong. But there are different subspecialties within neurology. And I think it's important for people to recognize that, because sometimes you may see a neurologist. For instance, I do some general neurology, but I may say, you know what? I think you need to see a neurophysiologist, right? To see if we can get down to the bottom of what's going on. So thank you for that explanation for the people, so people understand what a neurophysiologist is, and what that field entails. All right, so let's talk about nerve pain. So first, I want you to tell us, a little bit about what is neuropathy, right? Because every time someone comes in with nerve pain, they're like, I have neuropathy. And I'm like, well, who told you had neuropathy? And how did they assess to see if you had this neuropathy? And oftentimes there may not be that assessment to really diagnose it. It may just be symptoms. So what exactly is neuropathy? And then we'll talk a little bit more about some of the symptoms that we associate with neuropathy or with other nerve conditions or other apathies, that may be associated with nerve pain.
So neuropathy, simply put, is it combines neuro and pathy. So pathology, damage to what? The nerves. In essence, that's neuropathy. So there are over 150 different causes of neuropathy. You have neuropathy that can be hereditary or inherited. You have neuropathy that can be caused by different things in the environment. You have neuropathy where it can affect one nerve, called mononeuropathy, which in essence, a lot of people get carpal tunnel syndrome. That's one nerve, or they can get the nerve entrapped at their elbow. That's an ulneuropathy. That's one nerve involved. Then you have peripheral neuropathy or polyneuropathy, where you have nerve damage to several different nerves throughout the body. Another subtype that's not necessarily categorized into neuropathy is radiculopathy, where you can get a pinched nerve in one of the nerves that comes from the neck, the lower back, and less commonly the middle of the back. So there are a whole bunch of different types of neuropathies and causes for the neuropathies.
I did not know there were over 150 different neuropathies. I believe it, but I did not know. See, I learned something this morning. I learned something today. So this is really important. So over 100 different causes, right? And so what are some of the most common causes that we see? For instance, we know diabetes can cause nerve pain and neuropathy, but what are some of the most common causes of neuropathy that you see in your clinical practice?
So the three most common causes here in the United States are diabetes, unfortunately, alcoholism, excessive drinking, and medication side effects. And all three of those are what we refer to as acquired neuropathies, things that you can do something about, things that your parents didn't pass on to you. These are external causes of neuropathy. So those are the three most common causes here in the United States. The hereditary ones are less common. And then unfortunately, you have autoimmune diseases, which can come with neuropathies. Not uncommonly, patients that have lupus can have a history of neuropathy. One of the more common causes that people talk about, sometimes that can be associated with vaccines, are GBS or Guillain-Barré syndrome. And you also have the long-term or CIDP. That's also a type of autoimmune neuropathy. So the gamut of neuropathy runs very wild and rampant.
Yeah.
Then the less common causes are toxin exposures. Of course, you have the chemotherapeutic agents that can lead to neuropathy. So the world is, and then vitamin deficiencies, the most common one, B12, you have the thiamine deficiency. So there's so many different environmental, hereditary, as well as acquired causes of neuropathy out there.
So there is a wide range of reasons that people can have, neuropathic symptoms or nerve pain. Let's talk about what those symptoms are. So what are symptoms of nerve damage, so to speak? Typically I always say they come in different flavors, right? So I'm like, sometimes it's burning, so sometimes it's a bit of a misnomer because we call it positive symptoms, right? Meaning you got extra stuff that you ain't supposed to, but it's not positive, right? Because people don't like the way it feels. But people can have positive symptoms where they have extra sensations that are not supposed to be there, like burning, like numbness and tingling, like something's asleep, or they can have, negative or absence of symptoms where they have absence of feeling. Tell us a little bit more about some of those symptoms that people experience that will make us concerned about some type of nerve damage or possibly a neuropathy.
So, I mean, you covered them, you pretty much covered them. So, numbness and tingling, whether it's in your hands, arms, feet, legs, sometimes burning sensation. Classically, the alcohol, or what they call an alcoholic neuropathy, can be a painful neuropathy because it involves the small fibers or sensory fibers. Rarely do neuropathies cause muscle weakness. Many times when we see the neuropathies lead to muscle weakness, that's because there is damage to the large fibers. So nerves can have small fibers and large fibers. Classically, the thought is that the sensory fibers, or those fibers that can control sensation, are the small fibers, and those are the ones that are commonly affected first when it comes to neuropathy or nerve damage. That's where you get the numbness, the tingling, the burning, what we refer to as dysthesias or abnormal sensations. You can also have hyperesthesias or sensitivity to touch. I've seen diabetics where they say the covers can't touch their feet at night because they're so sensitive. And that's secondary to nerve damage. But then when it leads to weakness, which is very common in something like a CIDP or some of the hereditary neuropathies, that's where you have the damage to the larger fibers or the larger motor fibers of the peripheral nervous system. And that can really be debilitating in patients when they have that large fiber damage, just leading to muscle weakness.
So it's important to distinguish that, many of our more common or most common things like, diabetic related neuropathy, potentially alcoholism, will have sensory changes or changes in feeling, right? Whether it's lack of feeling or extra feelings, or normal feelings that are abnormal, like a cover touching your leg usually shouldn't be painful. Versus some of our either hereditary or autoimmune neuropathies may have associated weakness. So that's an important distinguishing factor, it sounds like, that with just kind of your run-of-the-mill diabetic neuropathy, you shouldn't have weakness associated with that. And that will be kind of a red flag, that maybe that's not the correct diagnosis. So
unless your A1C is through the roof.
Okay, so unless your hemoglobin A1C is, on 10 and stays on 10,
past
right?
10 in the 13s and 15s, then I've seen some examples of weakness associated with diabetic neuropathy.
Gotcha.
Another common thing people don't think of is issues with balance associated neuropathy. And it's inherent. What happens is if you have so much damage to your feet are very important to be able to tell your body where it is in space. So if your normal people can walk and they know where their feet are planted on the ground, well, if you don't have that sensation in your feet, then you can lose balance because your feet can't tell your body where it is in a certain space. So balance issues are another type of, and it's another area where people don't think that can be associated with neuropathy, but that's very common. If you notice that you put your feet on the ground or you step on something, say if your grandkids have Legos and you step on the Lego and you can't feel it, then that's a sign that you definitely need to seek attention.
Yeah, and I think that's important, right? So we talk a lot about balance, particularly in the MS space. We do have neuropathic pain. It's not neuropathy in the same sense as, let's say, a diabetic neuropathy, but people do have damage to their spinal cord, and the symptoms are very similar to what we see with neuropathies. And so we talk a lot about how, basically I say it's three things that affect your balance, right? You got to have feeling in your feet. Yeah. You got to be able to see, and your inner ear has to be working. Now, if you take one of those out, you'll have a little bit of difficulty with your balance. But if you take 2 out, you're going to fall over, right?
Yes.
So, which is often why people say, if they have neuropathy, I can't close my eyes in the shower, because if I close my eyes, I'm going to go over. It's because you're really knocking out 2 of those 3 things you need to know where you are in space and to be able to stand and not bump into things or fall over. So that's a really, really important point that you brought out, that you've got to be able to have that feeling. And if that feeling is gone, it can put you in danger to have walking abnormalities and potentially falling, because you don't have that sense of where your feet are on the ground. So thank you for bringing that up. Yeah, so so I have a lot of folks that come in with symptoms of nerve pain. We're trying to figure out what's going on. So how do we differentiate, or how do we kind of start the diagnostic process to figure out what's going on? Let's say somebody comes in, they say, hey, Dr. Green, I've been having numbness in my foot, or numbness in both of my feet, that's gotten worse. How do we kind of differentiate some of these causes of nerve pain, and how do we work it up, or what are some of the tests that we do to try to figure out why someone is having nerve pain?
So going back to med school 101, history and
Mm-hmm.
physical. So first conduct the history, see what type of pain, if they're having pain, or if it's just numbness, or if it's a combination of the numbness and pain. See which extremities are involved. Is it the hands, the leg, both, one or the other? Is it unilateral, bilateral? Then, of course, do the physical exam. See if it's your classic, like a diabetic, what they refer to as a glove and stocking distribution, going up to the hands and up in the feet. Of course, you do all the different sensory modalities that we do in neurology. You test their pinprick sensation. You test their light touch. You test their proprioception, and you look at their vibration. When you see that their proprioception has been knocked out, in other words, and I mean, Dr. Williams knows, you move the toes, tell me whether I move your toe up or down. If they're not able to tell you where their toe is in space as you're moving it, that can indicate a pretty significant sensory neuropathy. See if there's any motor weakness associated with the neuropathy. Now, not uncommonly for those severe distal neuropathies, if they have some associated motor weakness, you're not going to notice proximal muscle weakness or weakness in, say, their biceps, triceps, or their hip flexors, but they could have some slight weakness in their distal muscles, like their finger flexors, finger extensions, toe flexors, toe extensions. So basic history and physical, see how the neuropathy is distributed. Next thing
and so for the patient, they have to actually think about these symptoms before they come in. So it's helpful when you come to the doctor, to try to characterize what's going on with you. Because if we say, okay, you got pain, you like, where is it? I just know it's pain. It's like, well, what does it feel like? Is it prickly? Does it feel like something fell asleep and is waking up? Does it feel like it's on fire? So as a patient, for those who are watching, and advocating either for themselves or their family members, it's important that you try to kind of characterize what's going on with you. And that gives us a better sense of what's going on. If you try to think about it beforehand, figure out where it's occurring, think about, is there anything that makes it better or worse? Is there anything that, any time of day when you notice that it's worse? So thinking about all these things and making sure that you communicate them is extremely important and helps us to do our job better, because as you heard, it's over 150 different neuropathies. And those little details can make a big difference and make sure that we don't do unnecessary tests on you, because we have a better idea of what's going on. So I'm sorry to interrupt, but I had to interject that, like, amen, because I know that you and I both have gotten people, who've come to see us and they're like, I got pain. I'm like, well, where is it? Everywhere. It's everywhere. Okay. Well, what is it? What does it feel like? I don't know. And it's like, okay, well, it's hard to work with. I don't know. So you have a responsibility to try to characterize these things to help us to help you. All right, go ahead. I'm sorry, Dr. Green. I had to throw that in there.
No, yeah. And just to piggyback off of what you just said, Google is not your diagnosis and your diagnostic tool, because case in point, I just had a patient I saw Friday. He said, well, I went on Google because I had some numbness in my hand and they told me that I was going to die. So, please
Right.
do not utilize Google to describe your symptoms. As Dr. Williams just said, it's really important as a patient to take hold of your care in recognizing and understanding and being in tune with your body. No one can know your body like you know your body.
Right.
Dr.
Right.
Williams also brought up another good point in regards to what makes it better, what makes it worse. Classically, say with a carpal tunnel syndrome, patients will say they'll wake up in the morning, they notice their hand is weak, and then they shake it out, and then they go on through their day. Some people have the misnomer and they think, okay, well, it's my circulation, my hand's about to fall off because my artery's about to close off. No, it's not arterial. Typically, that's a whole nother set of symptoms that I'm not a vascular doc, so I'm not going to get into. Classically, with the alcoholic neuropathy, it'd be painful, and the patient said, well, I went 3 days without drinking just to see how I do, and I didn't have any. My pain got a lot better. Yes, because the alcohol was damaging your nerves, and now that you stop the
Right.
drinking, the nerve damage is less. So
Right.
it's important to be in tune with that. In regards to the workup, the next thing, the most common thing we'll do, or blood work. We have a general laboratory we refer to as a neuropathy panel. So you check the thyroid, the TSH, you check the vitamins, B12 and thiamine are common vitamins, folate are common vitamins that we'll oftentimes check as far as causes of neuropathy. Classically, check an A1C and what we refer to as a CMP or complete metabolic panel, because you want to check that glucose as well as a liver function test. And then if there's a suspicion for some of the other autoimmune diseases, you check for the inflammatory panels, the SED rate, C-reactive protein, the ANA, and maybe some of the rheumatoid factors, other autoimmune labs that can be classically associated with a neuropathy. There's also a Sjogren's, the SSA and the SSB, which those can commonly cause a painful neuropathy. Then, depending on what those labs show, oftentimes classically, a lot of docs would go straight for the EMG nerve conduction study to see how well the nerves are conducting impulses. If the neuropathy is very mild, sometimes those won't show up on the EMG nerve conduction study. So classically, like the Sjogren's neuropathy and the alcohol neuropathy, they affect very, very small nerve fibers. So the nerve conduction study can actually be normal. That doesn't mean that you don't have neuropathy. That just means that the small nerve fibers are affected and they're not showing up on the nerve conduction study. If you do the nerve conduction study, you see a lot of motor fiber involvement. Then you want to look at some of the autoimmunes and like the GBS and Guillain-Barré syndromes and CIDPs, because those can classically affect the motor nerve fibers also. Occasionally you will do a lumbar puncture if you have a high suspicion for a CIDP or a Guillain-Barré syndrome to look at the protein specifically. Rarely do you want to go to a nerve biopsy. Back when I was training, I would do the sural nerve biopsies. That's when you looked at all of the other different types of and ran tests for all the other etiologies, and you're like, crap, we haven't come up with anything. Because one of the things that's important when it comes to neuropathy is finding the cause, because as doctors, we can treat the symptoms all day, but until you get down to that etiology, especially if it's a reversible type of neuropathy, we can throw medications at it all day. But it's important to see if you can get down to the root cause of the neuropathy, treat that, and then thus help the symptoms potentially become reversible.
Yeah, yeah. And I think, so many things you said there are so important, but that getting to the cause and trying to understand what is the root or the etiology of these symptoms is extremely important, because it tells us what direction we need to go in to either try to reverse it, or in some cases, for instance, if someone's had severely uncontrolled diabetes for years, even if we get those levels under control, we may not be able to reverse it, but we could potentially prevent it from continuing to worsen. Because as you said earlier, if diabetic neuropathy or other types of neuropathies become severe, they can begin to affect the muscles. There's some that affect the muscles from the beginning, but some of them is just the sensation or the feeling. But if we let it go unchecked, it can continue to worsen and affect the muscles. So I think that that's an extremely important point as well, is getting down to that cause. So let's talk about this EMG. So I tell people, I refer people for EMGs all the time. And the first thing I tell them is, you ain't going to like me. Now, it's necessary, but you ain't going to like me when you go get that test. And I have done EMGs many, many moons ago in training. And I remember there was some people, now I'm not going to say if it was like my big burly guys or not, who would get really upset and walk out. And like my older ladies,
But sit there and take it like champs.
They would just take it like a champ, right? So
I gave birth to that epidural. This is nothing.
Right, exactly. They're like, child, this ain't nothing. But let's talk about this EMG test and let's talk about what to expect. I know you explained it a little bit earlier, but let's go into a little bit more detail. So this is one of the kind of big diagnostic tests that we do to try to differentiate or tell us what type of nerve problem you have going on, whether it's one nerve, a mononeuropathy, as you said, whether it's multiple nerves, a polyneuropathy. It can really kind of distinguish diabetic neuropathy, or in some cases, for some of my patients, where we're concerned about MS, they may have symptoms and go get an EMG and it's completely normal, not because they have a small fiber neuropathy, but because they have a problem in their spinal cord. Exactly. And the EMG really tells us about the peripheral nervous system and not quite as much about, let's say, the brain and the spinal cord, although we can see things like pinched nerves. So tell us a little bit, let's get into this EMG test. Tell the people what to expect. So what are the two components? What is, what should they expect with a test like that?
So the first part is the nerve conduction, oftentimes abbreviated as NCF, nerve conduction studies. So what that involves is sometimes it's done by the physician, sometimes it's done by a technician. They'll put electrodes on your skin and they administer shocks to assess how well, again, the nerves are conducting their impulses. And so you look to see if there's slowing, and so there's two electrodes. So you have one electrode placed proximally and then one placed distally. So what those electrodes do is not only measure how fast your nerve is conducting the electrical impulses, but to see how well and how intact that nerve is. That looks at the amplitude of the nerve. So you look at various components. You look at what's called a latency, how fast it's conducting, the velocities, as well as the height, which means how intact the nerve is. So that's the first part, the nerve conduction study. And that can
tell people it's not quite like sticking your finger in a socket. It's a little unpleasant.
Again, and I say everyone's pain tolerance is subjective. As Dr. Williams pointed out earlier, I mean, no offense to my men seeing this, but there's a reason why God made women the childbearing species.
Sorry, Phil.
Because it is uncomfortable. And then that's the first part, the nerve conduction. And the second part is the EMG and that involves the actual needle analysis of the muscles, because the muscle analysis can tell us not only about the muscle, but also about the nerve. And people say, well, which is worse, the shocking or the needle? And I jokingly say, well, there's crap in one and feces in the other. It just depends on how you look at it. I mean, they're both uncomfortable. There are other things you can be doing in life that are a lot more pleasant.
Right.
But it's uncomfortable, but it's not totally unbearable.
Right.
Yeah, I've had it done several times, both arms, both legs. I did it, when I was training, just to see how, just because as a physician, if I'm referring to someone for a test, I want to be able to convey what the experience is like. That's just me. I was like, yeah, this is what, and then I also had carpal tunnel. I've had surgery on this hand. So it's not comfortable. And the second part, the EMG, is the electromyography, which again, now analyzes muscle activity. And the muscle activity not only looks at the muscle, but it also looks at the nerves that's controlling that muscle. So we look for certain, what we refer to as insertional activity. Muscles, when they're resting, they're supposed to rest. They're supposed to be quiet. So if you see electrical activity in a muscle while it's at rest, that can indicate abnormalities not only in that muscle, but also in that nerve. And then once you activate the muscle, you see how many muscle fibers are firing off, how high the amplitude is. There are a whole bunch of dynamics that comes to interpreting the EMG part of it. And then you put the nerve conduction and the EMG together, and that will give you an idea as to whether this is a neuropathy, if this is a muscle disease, what type of neuropathy. Is it a primarily sensory neuropathy? Is it a motor neuropathy? And then if it's a neuropathy, you look at whether it's an axonal neuropathy or it's a whole whole different ballgame.
That is so fascinating. I guess that's why I'm a neurologist, right? Because I'm like enthralled here. Like, you can get all that information from those two components of a test. Like, that is really fascinating. And I think it's important for people to know that there are, what we consider kind of normal ranges that you compare it to, although each person is individual and each person is different. When you look at those test results, there are what we call normals, or a range of normals that we compare it to determine if it's too slow or, if it's not the right size, et cetera, et cetera. But I think it's absolutely fascinating to recognize, that test can tell us so much. And I know this is a little bit off topic, but what other things can EMG tests help us diagnose? And then we'll get back to neuropathy. So besides neuropathy.
So it also what we refer to is myopathy or muscle disorders. There are a whole bunch of different types. And muscle disorders aren't as common necessarily as nerve disorders, but you have the hereditary myopathies or muscle diseases, and you have the acquired inflammatory muscle diseases. So they can EMG can let you know if there's a primarily muscle disease. Neuropathy on EMG looks totally different than myopathy. Myopathy on EMG has small amplitudes, whereas neuropathy has large amplitudes. So that's a way to distinguish neuropathy. If someone comes in with muscle damage or muscle weakness, you use the EMG to distinguish, okay, is this a neuropathy that's primarily affecting the motor fibers, or is this a myopathy? It can also assess radiculopathy or pinched nerves in the neck. So if a person has weakness in their arm, you analyze different muscles as they correspond to a certain nerve root that comes out of the neck. And the same thing with the leg to see, okay, this person may have a pinched nerve in his C5 and or C6. For some of the patients that are watching, your doctor may say, well, I think it's coming from this area. You do the EMG. And if you do an EMG and you have a bunch of different muscles that are all controlled by the same nerve root, that can say, hey, well, this muscle, that muscle, and this muscle, what do they have in common? They're all controlled by the C6 nerve root. So this person likely has a C6 radiculopathy.
And then what about things like tremor or fasciculation? So I do get a lot of folks, people are aware of ALS, which is a very severe disease, that could be, that's often fatal. And so a lot of times when people get twitching, I remember in med school, if anybody got muscle twitching, we were all frightened that that's what was going on. But I do see a lot of folks, in the general clinic who'll be like, my muscles are jumping. Do I have Lou Gehrig's disease or what's going on with me? Or what about things like tremor and fasciculations? Can the EMG help with that as well?
Not as much tremor. So tremor is primarily thought to be a central nervous system disorder. So tremor, not so much. Lou Gehrig's disease, absolutely. So there are certain things that we look at on EMG as well as nerve conduction study. Classically, ALS affects the motor neurons. So you'll have the nerve roots look a certain way. It's kind of a mixed picture where, again, the muscle fibers at rest will fire off. But then when you look at the amplitudes will be high. So if a person isn't trained in neurophysiology, they will think it's a mixed nerve and muscle disease because the nerve fibers, the amplitudes will be high, but then the muscles will be active at rest. So, but then there's also this entity. Most people that come in with fasciculations have something called a benign fasciculation syndrome. So for anyone that has muscle twitching out there, unless you have a motor weakness, you do not have ALS. You probably just have a simple muscle twitch, or you've taken something like Benadryl. Classically, diphenhydramine, if you have allergies, some of the antihistamines can cause muscle twitching. So if it's just a muscle twitching with no other weakness or issues with breathing, then just stop the Benadryl or just let your muscle twitch. It's not going to be the end of the world for you.
Yeah. And I think that's important because a lot of it is reassurance. You know what I
Yeah,
mean? So, um,
absolutely.
yeah. All right. But now back to neuropathy. Now let's talk about, so if you will believe it, our time is getting close to the end. So let's talk about treatment. Now, as you alluded to earlier, nerve pain, honestly, is nerve pain. And so we often treat it very similarly when it comes to things like medication. So let's talk about how do we approach treatment of nerve pain? Like what,
So,
I mean, we don't have to say names, but what types of medications do we use? And how do we, kind of gauge what's effective and things like that.
again, the primary goal initially is to figure out the cause or the etiology.
Hmm.
So if it's something that is potentially reversible, you treat the cause. If it's secondary to B12 deficiency, you give them B12 supplementation. If they're diabetic and their A1C is high, you refer them to an endocrinologist. Or in the case of most of my family members, you smack their hands and take away the French fries.
How about that in the cake?
If it's medication there, and people don't understand, there are a lot of medications that have neuropathy as a side effect, particularly unfortunately, some of the cancer drugs are
Hmm.
notorious for causing neuropathy. Those you can't necessarily discontinue, but you do want to make people comfortable. So, of course, you said, so we do. Do we use the generic names of the medications that we oftentimes
Generic. Hmm.
generic? Okay.
Hmm.
So we have, of course, the gabapentin and pregabalin. Those are thought to work on the GABA transmitter. Those are the two most common ones. And then there's also duloxetine, which was classically marketed, I think, as an SNRI or SSRI. Don't quote me.
Hmm.
But that can also help with neuropathic pain. And then you also have the TCAs or the tricyclic antidepressants. You have the amitriptyline and nortriptyline, which can be used to treat neuropathic symptoms. Particularly, I like those because one of the side effects are drowsiness. And then, especially patients have coexisting mood symptoms. I'll oftentimes use one of the TCAs to help with their neuropathic symptoms. Help with their neuropathic symptoms. If it's something autoimmune, then that's when you may potentially throw in immunosuppressants. So for
Hmm.
the CIDPs and the GBSs, you got the steroids, you have the IVIG, and sometimes if it's a primary autoimmune neuropathy, then you want to think about some of the other immunosuppressants that are out there and
Hmm.
just tailor it based on the autoimmune disorder and autoimmune process that is suspected or that you find diagnostically.
Absolutely. And so, what I often tell my patients is that oftentimes the medicines that we use to treat nerve pain fit in two categories, as you discussed, antidepressants and often anti seizure drugs. And the reason I tell them that is because they will inevitably go to Google and I will say, listen, now Dr. Williams is not trying to sneak and give you an antidepressant. That's not what I'm saying. I'm telling you up front that these are the categories that work well for nerve pain, right? Because very few of our medicines, are what we would say indicated for neuropathic pain. So it's essentially, years of people saying, well, you know what, this didn't help my depression, but it sure helped
It
that
should have my
tingling
head.
that I
That
had in
was
my
tingling
leg.
his head.
You know what I mean? My tingling is better. My seizures ain't better, but my tingling is better. And so that is often how we find out that certain medications work for other things. So I always tell people that up front, those are the categories, and sometimes we have to look and see if they're on other antidepressants. Well, maybe we don't want to mix these two. Maybe we'll want to go with an anti-seizure drug, or if they have other issues, maybe we don't want to do that. We want to go that route. If they have, let's say, mood issues that we kind of want to address as well, but those are kind of the typical categories we use. Now, what about the use of procedures? Now, sometimes I have folks who have nerve pain that is really severe. We've tried the medications and either we have maxed out on the medications or we've gotten to side effects, or we've tried 4 or 5 and they're still in significant pain. Sometimes I'll refer them for certain procedures like epidurals or nerve ablation. We don't have to get into the weeds with that, but are there some procedures that may help as well if, let's say, our traditional medications are maybe doing a part, but they're still in significant, discomfort and not able to function?
Unfortunately, for the classic polyneuropathy, because poly involves multiple nerves, there
Hmm.
isn't one specific procedure that will help with that.
Hmm.
It's not really possible these days to stick a needle in every single nerve. Unfortunately, that may
Right.
be bothering somebody when it comes to polyneuropathy, or
Mm-hmm.
classically what's called peripheral neuropathy. If
Mm-hmm.
it's a mononeuropathy, such as carpal tunnel syndrome, of course, there's surgical intervention. There are injections you can do. Before I actually underwent surgery, I had an injection in my median nerve in the wrist, and I also had to
Mm-hmm.
have one on my left hand.
Mm-hmm.
And then I also, after the injections didn't work, because what you don't want to do is undergo repeated injection, because that's repeated trauma to the nerve, and that could
Mm-hmm.
create scar tissue. So I then underwent a carpal tunnel release, where they went in, did a small procedure, and released that pressure off of the nerve. Same thing in the neck, like you mentioned before, when it's a radiculopathy or pinched nerve in the neck of the lower back. A doctor can go in, most commonly under what we refer to as fluoroscopic guidance, or use an x-ray to put medication towards the
Mm-hmm.
area where the nerve is being affected. And there are
Mm-hmm.
several things with that. There's epidural steroid injections, there are facet injections, there are RFAs, or radiofrequency ablations. Then you have there's spinal cord stimulators. And then, if long term, you can have disectomies, where they remove parts of the disc, shave the
Mm-hmm.
disc, replace the disc. There's all kind of
Mm-hmm.
stuff you can do
Mm-hmm.
for the radicular component of things. I'm sorry,
Gotcha.
yeah, the radicular symptoms, if
Mm-hmm.
especially if it's severe.
Yeah, so sounds like with polyneuropathy, right, which again we're talking about kind of our typical diabetic neuropathy, the best things to do are to try to get the
Reverse.
cause under control, and then we use our medications, but maybe procedures are not as helpful with that particular problem. But with other problems, if it's one nerve or something in the neck, etc., then sometimes procedures can also help with those symptoms. All
Absolutely.
right. Well, it looks like Dr. Green, our time is up. And this has been an amazing conversation. I know it's going to be so informative for our listeners. And the last question I always like to ask all my guests is, what are you excited about in the field? So you, like myself, went into neurology because, I felt like it was on the cutting edge of medicine, that we have so many more, advances before the end of my career. What are you excited about in the field?
Well, neuromuscular disease is near and dear to my heart. My mom has something called myasthenia gravis.
Mm,
And right now, there are so many medications that are coming out. And she has a very specific one called musk myasthenia. Myasthenia gravis is already rare. Then you have musk myasthenia, which is even more rare. And that one
mhm,
can be more difficult to treat, and unfortunately more deadly.
mm,
So, and this, like I said, this is just me being selfish, plugging out my mom. But there are so many medications coming down the pipeline that are specifically geared to patients that have musk myasthenia. And again, me being in the neuromuscular field, it's just something that I'm personally excited about. Most
mm.
of your audience members are going to be like, what in the world is that? But that's just for me personally.
Yeah,
I'm also
yeah.
excited about the things that are coming down the pipeline in regard to dementia, and the
Mm,
various medications that are coming out for that can potentially halt the progression of the disease. I currently see the retired NFL players in my practice, and a lot of them are developing early onset Alzheimer's disease. We're talking
mm,
about men in their 50s,
mm,
40s, and 50s who already have
mm,
signs of dementia. So to
mm.
be able to help someone that's dealing with such a debilitating disease so early, that's really exciting for me to see also.
Yeah. Well, listen, the advances don't stop. There's just so much going on, and it's an exciting time to be a neurologist. And thank you for sharing your wisdom and knowledge with our Brain Chat audience. I'm sure they will get a lot out of it, and hopefully be a little less scared about those EMGs I refer them for. Um, but thank you, Dr. Green. Thank you to our Brain Chat friends, and we will see you again in 2 weeks.